Part A. In this part of the test, you'll hear two different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now turn over and look at the notes for extract 1.
You hear an otolaryngologist talking to a patient named Terry Butler. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at your notes.
Good afternoon, Mr. Butler, is it?
Yes, Terry Butler.
So your GP has referred you because of a problem you've been having with your nose. Can you tell me more about it, please?
Well, it's usually when I first wake up, I get a terrible crusty mucus, but it tends to stay around for the whole day. It's been irritating me for a couple of months, actually. I initially thought it had just resolved by itself, but it hasn't. The thing is, and I know it's a bit disgusting, but sometimes when I try to get it out, I've had a little bit of bleeding. It's not a lot by any means, but enough to notice.
Right, okay.
I've also noticed, for example, when my wife puts on perfume, it's my sense of smell. I can't seem to detect it as strongly these days, so I'm a little concerned over that. I mean, I can still breathe, of course, but it's worrying. I actually thought I was allergic to something because we'd recently adopted 2 cats, or maybe it was, I don't know, dust mites or the season, because I suddenly started sneezing. Not all day, but still quite often, regular sneezing. But that's not the case, apparently. I know this condition isn't dire, but it does affect my life. The blocked up feeling can really hurt sometimes.
I'm sorry to hear it's caused you so much worry.
Well, I'm also concerned about my job. I'm a hire car driver, and it's mostly for high-end clients, so it involves a certain degree of professionalism. The last thing I need is to be seen constantly playing with or twitching my nose, or worse still, sneeze and cause an accident.
So you don't believe it's allergies related?
Well, not as far as I know. I've been to my GP, as you know, and tried to rule things out. First, I had a skin prick test, and that didn't show anything, so I went away thinking it'd clear up. But then after a few weeks, it was still annoying me, so I had a blood test, but that apparently came back clear. But I keep thinking maybe it's something less common, and that's why nothing's shown up. My GP asked if I'd been ill because he thought perhaps it was caused by a viral infection, but I hadn't been. He also asked if I was taking any medications that he wasn't aware of, like beta blockers or antidepressants, which I wasn't. In fact, the only thing I'd started using around that time was a nasal decongestant spray that I'd bought from the chemist, which he then advised me to stop. He thought maybe I'd been using it too much, so I did, of course, but doing so didn't seem to make a difference.
I see.
And he suggested I try a few to see if they make a difference, so I got a humidifier. That apparently helps with the dry air and therefore to loosen the mucus, which was okay, but didn't make too great of an impact. He told me how to make up a salt water solution. It's much cheaper than buying it from the chemist. I still use it now, and that helps a little too, but just not for long periods of time, so I have to keep it up a few times throughout the day. Before going to bed, he said I should take an antihistamine, but again, it just doesn't seem to last too long, and before I know it, I'm feeling the same as before taking it.
And how's your health generally?
I'm typically as fit as a fiddle. I quit smoking 14 years ago because of a number of recurring lung infections at the time. They were enough to make me wake up to myself and finally go cold turkey. As for alcohol, well, I've been having my regular nightcap of whiskey for 20 years. Always the same brand, and I always stop at 2. As I said, I'm reasonably fit for my age. I go to the gym regularly. I've been involved in a cycling club for a number of years. We're a medium distance group and average around 60 kilometres an outing, so not too shabby.
That's great.
So, do you think there could be something wrong with my nose?
Well, that's what we intend to find out. The way we do that is by performing a nasal endoscopy. It's a very thin and flexible camera.
You hear a general practitioner talking to a patient named Jane Brown. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at your notes.
Welcome, Miss Brown. May I call you Jane?
Yes, of course.
I understand you've just registered as a new patient with this practice.
Yes, I've just recently moved to the area and my old doctor's a little too far to travel.
No problem, and you've come here today because of some discomfort in your left arm, is that correct?
Yes, that's right. Well, it's actually a pain along the bone on the outside edge of my forearm. It's kind of more numb than anything and sort of spreads to my little finger. It started about 2 weeks ago, I think, and comes and goes, but there's definitely something wrong there. It's getting quite painful, especially at night. It's even caused me to wake up a few times. And sometimes if I stretch out my arm suddenly or if I bend it with any force, the pain, it's hard to describe, kind of like a guitar string being wound really tight.
Okay, and have you tried anything for it?
Well, I asked a few friends and they said it's probably a pinched nerve and to try just resting it on a pillow. So I did, but that didn't make a difference. So I looked it up online and it was recommended to put some ice on it and also a heat pack, alternating a warm compress with ice, kind of swap from one to the other and also see which one worked the best. It also said I can take anti-inflammatories, which I did for about a week, and it made very little difference. It also said I should do some gentle stretching exercises, but at the time they hurt to do, so I didn't really follow through with them.
Right, and you're 22. Are you working or studying?
I'm still at university. I'm doing a Bachelor of Science. It's my final year, so it's pretty hectic. I spend most of my days sitting at a computer.
Okay, can you tell me more about that? How long you'd spend at the computer, I mean?
Well, I'd sit there anywhere up to 10 hours or even more some days. It's pretty uncomfortable at home. We have a really large desk. It's one of those old antique things. My dad bought it at an auction. It's just that it's so high, so my forearms and I guess also my wrists have to lean against the edge of it when I type. Sometimes I sit there for a few hours and don't really move them very much. If I'm concentrating on my work, then I don't notice the kind of pressure I'm putting on them, but I often see that I have deep creases kind of halfway down my arms when I stand up, so I guess it might be quite a lot. Now that I'm saying this, it's pretty obvious that that might be the reason for the pain.
I'd certainly say it's a contributing factor. Is that the same at university?
Well, if it's a tutorial, then I sit the same way as at home because the tables there are terrible and I'm so used to it. If it's a lecture, we have those little flip-top tables, so I can sit properly with my back straight because there's nothing to lean against and they're a comfortable height. I also have a question, if it's okay.
Yes, of course.
Would playing a lot of sport help this kind of injury or make it worse?
It would depend on the type and the intensity.
Well, I play netball on Tuesday nights, not for a competition, just a mixed group of friends. I also swim twice a week, but about half a year ago, I joined the university rowing team. That's what makes me really feel it because of the action of my arms having to stretch and bend at the elbow so much. And that causes really intense pain. It's hard and you need to be fairly strong, but I enjoy it, so I want to keep at it if I can. That's another reason I'd really like to get this sorted out. I haven't played any sport for the last 7 days because of the pain, but I really want to get back to it. It's kind of addictive.
A break's a good idea. They sound rather rigorous. What I'd like to do now is examine not only your arm, but also your neck and spine.
In this part of the test, you will hear 6 different extracts. In each extract, you will hear people talking in a different healthcare environment. For questions from 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now look at question number 25. Question 25. You hear 2 doctors having a discussion about chemotherapy for bladder cancer. Now read the question.
Doctor, Could chemotherapy inside the bladder reduce recurrence of cancer?
According to a recent study, patients who had the chemotherapy drug gemcitabine placed inside their bladder following the resection of the tumor had fewer recurrences. Out of more than 400 subjects, 384 completed the trials and were included in the study, which randomized them to receive the chemotherapy drug called gemcitabine. To treat the bladder cancer, they implanted it into the bladder and let it settle there for an hour, and the other group with saline without gemcitabine in it. They kept the patients under observance for every 3 months for 2 years, thereafter every 6 months for another couple of years. What they observed was the recurrence were 34% less. The purpose of this study was to prevent bladder cancer from invading the muscle wall of the organ. Moreover, this is a very simple method without any significant side effects. Question 27. You hear two doctors discussing occupational therapy for improving visual function. Now read the question.
Doctor, can visual function be improved through occupational therapy?
Well, findings proved that occupational therapy for patients with poor vision performed at their home and directed particularly toward helping them with both meaningful and challenging tasks, helped avoiding depression that actually improved the visual function as well. It was observed that those with milder visual impairment actually performed much better on these questionnaires after the occupational therapy group, whereas those who were in the supportive therapy attention control group could not improve their visual function measures. Therefore, the occupational therapy role not only improved in some of these depressive symptoms, but also in this specific subset of patients with mild impairment did improve their visual function as well. The comprehensive approach to rehabilitation, including in-home occupational therapy for those with visual impairment, is the key to improving visual function. Question 28. You hear two doctors talking about why primary doctors should not perform eye screening. Now read the question.
Doctor, why shouldn't the primary care doctor perform eye screening of the patients?
Well, according to the recent recommendations of the United States Preventive Service Task Force, the primary care doctor shouldn't include a vision screening to the list of primary tests for his patient in his office. To know why vision screenings may not trace out the precise vision impairment, we need to look at the factors that can restrict the effectiveness of the results. Many vision screenings are performed only for distance visual acuity, and it does not give any indication of how well the eyes work together or focus up close. It also does not give any detail about the eye health. Although certain screenings may include a plus lens test for farsightedness and eye coordination tests, even these screenings will often fail to detect many vision defectiveness. Often, a vision screening is conducted by primary doctors or administrative personnel who have little training, who haven't the complete knowledge to assess screening results. Even if the screenings are performed in pediatricians or primary care physician's office, the scope of vision screening may be restricted by the type of lab equipment. Question 29. You hear two doctors discussing dysphagia after the use of breathing tubes in ICU patients. Now read the question.
Hello, doctor. Is trouble with swallowing common following use of breathing tube?
Breathing tubes are meant to save lives, and they are often used for critically ill patients as well as during various surgeries. However, using breathing tubes has a side effect of difficulty in swallowing called dysphagia. In the ICU, patients had breathing tubes down their throat, typically more than 48 hours, will have a minor difficulty of swallowing and some voice problem as the tube is pulled. If it becomes worse, it can last years afterwards. According to the findings, most patients in this 5-year study recovered from their dysphagia within 6 months. However, there are also cases of the condition lasting up to 5 years. The good news is that even in patients with the prolonged periods of dysphagia, ultimately they did recover some function. Question 30. You hear two doctors talking about risk factors for kidney donors. Now read the question.
Doctor, how risky is donating one of our kidneys?
Well, there's an online risk tool to calculate the long-term risk of end-stage renal disease in people who are willing to offer kidney donation. This tool includes many characteristics in contrary to single characteristics used earlier. This multitude of characteristics help develop a comprehensive picture of risk in donating a kidney. This tool incorporates 10 different characteristics that are specific to the person willing to be a donor and provides an estimation of the absolute risk of end-stage renal disease over a certain period of time, say 15 years.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear the doctor briefing his staff about guidelines for the early detection of cancer. You have 90 seconds to read questions 31 to 36. Guidelines for the early detection of cancer. I am going to explain to you the guidelines for screening different types of cancers. These screening tests are suggested to detect cancer before the patient develops any symptoms. Colon and rectal cancer and polyps. Starting regular screening at the age of 45 is suggested for people at average risk of colorectal cancer. The screening can be performed either with a sensitive test that examines for cancer signs in the stool of the person or with an exam to look at the colon and rectum. This can be done either with a sensitive test that looks for signs of cancer in a person's stool or with an exam that looks at the colon and rectum. If the person is maintaining a good health, he should continue with regular screening through to the age of 75. For people aged 76 to 85, they should confirm with the physician whether continuing with the screening is right or not. People above 85 should no longer get colorectal cancer screenings. If the person wishes to be screened with a test other than a colonoscopy, any abnormal result should be followed up with a colonoscopy. Cervical cancer. Cervical cancer screening should begin at age 21. However, women below 21 years should not be screened. Women between 21 to 29 should have a Pap screening done once in every 3 years. However, HPV screening should not be performed for this age group unless it is required after an abnormal Pap test result. Women between 30 to 65 should have a Pap test in addition to HPV test termed as co-testing done every 5 years. This is the most suggested approach. However, having a Pap test alone is also okay for this age group. Women above 65 who have had regular cervical cancer screening for the past 10 years with normal results should not be tested for cervical cancer. Once screening is discontinued, it should not be started again. Women with a history of severe cervical precancer should continue screening for at least 20 years after that diagnosis, even if testing goes past age 65. The women whose uterus and cervix have been removed, total hysterectomy, for reasons not related to cervical cancer and without any cervical cancer history or severe precancer should not be screened. Women vaccinated against HPV should still follow the screening recommendations for their age groups. Women with a history of HIV infection, organ transplant, DES exposure, etc. may require a different screening schedule for cervical cancer. Breast cancer. Women from 40 to 44 should have the choice to start annual breast cancer screening with mammograms. Women from 45 to 54 should get yearly mammograms. Women above 55 may get mammograms once in every 2 years. Screening should continue as long as a woman is in good health and is expected to live more than 10 years. Women should be well informed with the known benefits, potential harms, and limitations linked to breast cancer screening. Certain women with a genetic tendency, family history, or certain other factors should get screened with MRIs along with mammograms. Endometrial cancer. I would recommend that during menopause, every woman should be informed about the risks and symptoms of endometrial cancer. Certain women with a disease history may need to opt for a yearly endometrial biopsy. Lung cancer. I would recommend yearly lung cancer screening with a low-dose CT scan for certain people prone to lung cancer who meet the following criteria: aged between 55 to 74 years and maintaining good health, and stopped smoking in the past 15 years, and having a minimum of 30 packs per year smoking history. Prostate cancer. I would recommend that men make an informed decision after consulting with a physician whether to be screened for prostate cancer. Research has not yet proven that the benefits of screening outweigh the harms of testing and treatment. Therefore, I believe that men should not be screened without understanding about the risk factors and benefits of screening and treatment. Starting from the age of 50, men should consult a physician about the risk factors and benefits of screening so that they can decide if screening is right for them or not. If they are African American or have a father or brother who had prostate cancer before the age of 65, one should consult a physician right from the age of 45. If one decides to be screened, he should get a prostate-specific antigen blood test with or without a rectal exam. How often he will be tested will depend on his prostate-specific antigen level. Extract 2. Questions 37 to 42. You hear the doctor giving a lecture on the effect of disrupting gut-brain communication. You have 90 seconds to read questions 37 to 42. According to research findings, disrupting gut-brain communication may affect memory and learning abilities. The link between memory and food is a fundamental human experience that we all can relate to. However, the findings have unveiled an intriguing explanation behind this phenomenon, illustrating how strongly the second brain in our gut communicates with our brain. A massive mesh of neurons termed as second brain lies inside our gastrointestinal tract. While this neuronal control system primarily functions independently to manage our digestive system, the study reveals that this neuronal control system communicates with the brain directly through a long nerve called the vagus nerve. The vagus nerve mediates a great deal of metabolic communication between the gut and the brain. For instance, the study revealed how feeding behavior initiated by hippocampus activity is directly activated by vagal nerve stimulation, mediated by signals from the gastrointestinal tract. It appears obvious that signals from the gut would be communicating with the brain in this way, allowing us to know when we should stop eating. But what if these gut to hippocampus communications covered satiety clues or more than simple hunger? Could they also impact cognitive and other memory processes regulated by the hippocampus? A study conducted on this topic that utilized a novel rodent model that terminates about 80% of gut to hippocampus communicators while still retaining fundamental brain to gut motor signaling. The study revealed that when this gut-brain pathway was detached, the rats displayed impaired episodic and spatial working memory. That means the rats could not effectively generate and access spatial memories provoked by the gastrointestinal system. With this disrupted pathway, a fascinating link between our gut and memory is hypothesized. When rats locate and eat a meal, the vagus nerve is activated and this global positioning system is engaged. Therefore, it would be advantageous for an animal to remember their external environment to locate the food again. The artificial electrical stimulation of the vagus nerve can increase memory function. However, this is the first study to find an endogenous connection from the gut through to the hippocampus that mediates this cognitive pathway. Interestingly, this study revealed that the specific vagal nerve disruption studied here did not affect social learning, body weight, or anxiety. The study concluded by raising a concern over the lack of research in this subject. It is recommended that common bariatric surgeries, such as a gastric bypass, have been found to reduce the effectiveness of vagal nerve signaling to the hippocampus. Moreover, a recently approved FDA obesity treatment called V-block therapy has been effective in weight loss by electrically disrupting the vagus nerve.